Gentlemen, do you wake in the dark to find your bladder has already decided your night for you? If you have, you are not resigned to that fate. I'm Dr. Michael Harris, urologist, and in my clinic, I see the same story over and over. A man who has stopped planning his evenings around sleep and starts planning them around the next trip to the bathroom. That change is not an inevitable sentence of aging. Small, science-backed habits can change what your bladder and prostate do at night and during the day. Tonight, you can start one of them. If you want more practical, science-based strategies for men over 60, please hit like and drop your country or state in the comments. Tell me where you're watching from, and stay with me through the 5 habits I'll lay out. Now, let's get to the heart of this. 5 daily habits ranked from useful to game-changing, each with why it works, the evidence behind it, a precise, doable protocol, and a short, real-world example from a patient I've treated. Habit 5 is regular aerobic activity. Move your body every day. The mechanism is straightforward. Improved circulation reduces chronic low-grade inflammation, helps the pelvic tissues clear metabolic waste, and lowers abdominal and pelvic pressure that can push against the bladder. Large cohort studies published in general medical journals show men who keep to moderate activity have lower odds of developing bothersome lower urinary tract symptoms over years. The practical protocol is precise and short. Aim for 30 minutes of moderate activity daily, or 3 10-minute brisk walks if that fits your schedule better. Keep the intensity at a level where you can speak in short sentences, but would rather not sing. If you're starting from low fitness, begin with 2 10-minute walks and add 5 minutes every week. I remember Mr. Jacobs, 67, from a coastal town in Oregon. He told me he spent most afternoons in his recliner after dinner, then woke twice each night to urinate. We agreed on a simple plan: 3 10-minute walks after breakfast, lunch, and dinner for 4 weeks. He tracked it on a kitchen calendar. Within 3 weeks, the night trips fell from 2 to 1, and by 2 months, he said the walks had become the best part of his day. He slept deeper and felt less urgency during meetings. The cumulative effect of movement compounds. Circulation improves, weight often drops a little, and inflammation eases. Keep the walks daily, they stack. Habit 4 is to reduce alcohol and other bladder irritants. Think of alcohol as a flare for your prostate and bladder, a little gasoline on a smoldering fire. Physiologically, alcohol increases urine production, a diuretic effect, irritates the bladder lining, and can worsen nocturia and urgency. Observational research in urology and public health journals consistently links higher alcohol intake and more frequent nocturia. The practical protocol I give patients is blunt and actionable. Limit alcohol to no more than 3 standard drinks per week, and avoid any alcohol within 3 hours of bedtime. Reduce caffeinated beverages, especially late afternoon and evening, by switching to decaf or herbal tea. Keep the total daily caffeine to a modest amount and track where it comes from: coffee, cola, chocolate. For men who drink socially, replace 1 drink with water or a low-sugar mixer and set a weekly cap. A patient vignette. Mr. Singh, 72, in a Canadian suburb, loved a nightly glass of wine but found himself up repeatedly. He cut his weekly drinks from 7 to 2 and stopped drinking after dinner. Within 2 weeks, the urgency eased and nocturnal awakenings fell nearly in half. He told me the small sacrifice at dinner was worth hours of sleep regained. Habit 3 is weight management and portion control to reduce abdominal pressure. Excess belly weight pushes on the bladder and prostate from the outside, raises intra-abdominal pressure, and fuels systemic inflammation that affects prostate tissue. Research from population cohorts shows that modest weight loss, around 5 to 10% of body weight, correlates with meaningful reductions in urinary symptoms in many men. The protocol is concrete. Aim for a 10% weight loss if you are overweight, achieved gradually. Start by reducing portion sizes by roughly 20% and focus on whole foods, vegetables, lean proteins, and whole grains. Combine this with the daily walking above and add 2 short resistance sessions per week, bodyweight squats, seated rows with a band, or light dumbbells to preserve muscle. A reasonable target is losing about 1 to 2 pounds, 0.5 to 1 kilogram per week until you reach the 10% mark. Mrs. or Mr. Thomas, Mr. Thomas, 69, in Manchester, found that cutting portions and walking made a large difference. At his baseline, he described frequent daytime urgency that made him avoid long drives. Over 3 months, he lost 12 pounds and reported fewer interruptions and a stronger stream. Weight changes don't fix everyone, but reducing that abdominal squeeze often relieves the mechanical pressure that worsens symptoms. Habit 2 is dietary choices that lower prostate inflammation, particularly increasing cooked tomatoes and healthy fats for lycopene absorption and lowering processed foods. The prostate responds to oxidation and inflammation. Lycopene, an antioxidant abundant in cooked tomatoes and tomato products, has been associated in epidemiological studies and smaller clinical trials with modest improvements in prostate health markers and symptoms. The protocol is simple and delicious. Include cooked tomato-based foods at least 3 times per week, tomato sauces, stewed tomatoes, or baked tomato dishes, paired with a small amount of healthy fat like olive oil to improve lycopene absorption. At the same time, reduce highly processed, high-sugar foods and excess red meat. Think Mediterranean plate. Vegetables, legumes, oily fish once or twice weekly, and tomato-rich dishes. A short clinical example. Mr. Alvarez, 66, from Brisbane, started adding a bowl of warm tomato and lentil stew to his dinner 3 nights a week and used olive oil liberally. After 6 weeks, he reported a subtle but noticeable decrease in the frequency of getting up once in the night. And after 3 months, he felt his daytime urgency had softened. These dietary changes aren't instant magic, but they support the tissues and lower the inflammatory load that keeps the prostate swollen like a sponge. Now we come to Habit 1, the habit I ask you to make the priority tonight. Habit 1 is timely, more complete bladder emptying coupled with simple pelvic floor awareness techniques. When your bladder sends a strong signal, don't wait until you're bursting. Don't chronically over-distend the bladder. Emptying the bladder fully reduces residual urine, which decreases bacterial overgrowth risks, bladder irritation, and the sensation of urgency. Mechanically, think of the bladder as a balloon and the prostate as a sponge nearby. If the balloon overfills and stretches, it presses more on that sponge, and the sensations intensify. In my clinical experience, and in several urology-focused studies, men who adopt consistent voiding habits, regular timed voiding, double voiding, and learning to relax rather than push, often report rapid symptom relief. Here is the precise protocol I teach and have patients start tonight. First, set a simple schedule. Over the day, void roughly every 3 to 4 hours. Do not leave 8-hour gaps if you are prone to urgency. Second, practice the double void technique before bed and after long intervals. Urinate, stand, and walk for 30 to 60 seconds, then sit and try to void again. Third, learn a pelvic floor relaxation sequence. Sit comfortably, take 2 slow diaphragmatic breaths, then gently bear down and relax the pelvic floor muscles. Do not strain or push hard. If urgency hits, pause, breathe slowly, and try to walk calmly to the bathroom rather than blurt and strain. Finally, when you feel the urge, aim to void within about 5 minutes rather than habitually holding for long periods. This reduces overdistension and the cycle of urgency. I slow down here because this one matters right away. When your bladder sends a signal, go. When your bladder sends a signal, go. Practice the double void tonight. Before you go to bed, empty, stand, breathe, sit, and try again. Repeat the sequence in the morning. Make this your ritual for the next 2 weeks, and you will see whether your bladder relaxes into predictable intervals instead of demanding attention at random times. Mr. Baker, 70, from Toronto, had a habit of holding it during morning errands because he didn't want to stop at every store. He told me he thought this would strengthen him. Instead, it left him with worse urgency and occasional leakage. We worked on scheduled voiding and double voids, and in 10 days his leaks stopped and his confidence returned. He described the first night after starting the routine as the best night's sleep in months. As you adopt these habits, remember they work together. Walking helps weight loss. Weight loss reduces pressure and makes the dietary changes more effective. Reducing alcohol lowers irritation, so the timed voiding becomes easier. The physiology is cumulative. Circulation, inflammation, and mechanical pressure respond when you change multiple small inputs. You may be wondering about medications, tests, or when to see a doctor. Lifestyle habits often reduce symptoms and improve quality of life, but they do not replace medical evaluation. If you experience severe pain, fever, blood in the urine, sudden inability to pass urine, or a rapid worsening of symptoms, seek immediate care. For persistent symptoms despite lifestyle changes, a clinical assessment can determine whether medication or procedural options are appropriate. Before I close this segment, let me underline a few practical starters you can begin tonight. Take a 10-minute brisk walk after dinner. Skip the glass of wine tonight and replace it with water. Reduce your dinner portion by 20%. Add a warm tomato-based side to your meal this week, and perform a double void before bed. Choose one of those 5 and start tonight. Make it simple, track it on the kitchen calendar, and give it 2 to 8 weeks to show effect. Many men report early improvement within weeks. More substantial changes often take a few months as habits compound. A quick, necessary note on safety and limits. The guidance I've given is educational and based on general clinical evidence. It is not a substitute for personalized medical advice. If you have sudden severe pain, any blood in the urine, fever, or an inability to urinate, seek immediate medical attention. If you are on medications that affect urine production or blood pressure, or if you have other chronic illnesses, check with your clinician before making abrupt changes to diet or exercise. I'll pause here to let you absorb these practices. In the next section, we'll explore simple ways to track progress, how to troubleshoot common obstacles, and a few practical adaptations for travel or long drives. For now, pick one habit, start it tonight, and note how your body responds over the coming days. Small, consistent changes make a real difference. Tracking progress, the practical tools that make change visible. Begin with a simple bladder diary. For most people, a 1 or 3-day diary is sufficient to understand patterns. For treatment decisions, you or your clinician may collect 7 days. The diary should be plain and quick to complete. Record these columns. Time of each void. Volume, use a measuring container or estimate as small, medium, large if you cannot measure. Urgency score. 0 equals no urge, 1 equals mild, 2 equals moderate, 3 equals strong, urgent. Leakage. Yes, no. Small, large. Fluid consumed in the preceding hour. Type, water, coffee, alcohol. Notes. Stress, bowel movement, travel, medications. At the end of each day, total the number of voids, the number of urgent episodes, total urine volume if you measured, and nocturia events. Over a 1 to 2 week span, you will begin to see patterns. Times of day with highest frequency, which beverages precede urgency, whether constipation and bowel habits line up with worse bladder control, and whether scheduled voiding has increased your average voided volume. How to interpret the numbers. Practical rules of thumb. Voids per 24 hours. More than 8 suggests high frequency. Aim to reduce gradually toward a personal target set with your clinician. Nocturia. 2 or more nightly voids is common with age, but is also treatable. Reducing late evening fluids and addressing sleep apnea or diuretics may help. Maximum voided volume. This gives you a target. If your largest daytime void is 150 to 200 milliliters, work to increase it in small steps by delaying the urge by a minute or 2 and practicing urge suppression. Leakage events. Note triggers. Activity-related leaks suggest stress incontinence or mixed physiology. Urge-associated leaks suggest overactive bladder. Simple charts, a kitchen calendar, or a smartphone app can be used. The tool matters less than the habit of recording. Seeing steady small improvements, one fewer night void, one less urgent rush per day, builds confidence and adherence. Troubleshooting common obstacles. Stubborn urgency despite good technique. Recheck your bladder diary for hidden drivers: caffeine, artificial sweeteners, carbonated drinks, late alcohol. Look for polyuria, excessive urine production. A 24-hour urine total above about 2.5 to 3 liters suggests high fluid intake, uncontrolled diabetes, or diuretics as culprits. Try short, structured urge suppression drills. Stop, take 5 slow diaphragmatic breaths, perform 3 quick pelvic floor squeezes, a firm squeeze, like stopping a flow, held briefly, then relax and walk deliberately to the bathroom. The squeeze can inhibit the bladder reflex. The breathing calms the urgency cascade. Combine with the earlier relaxation sequence when voiding. If pelvic floor muscles feel tight or painful, avoid excessive squeezing and seek a pelvic floor physical therapist. Paradoxical tightness can worsen symptoms. Difficulty performing double void or incomplete emptying. Ensure you are relaxed. Warm shower, comfortable position on the toilet, diaphragmatic breaths before trying to empty. Try the lean forward posture on the toilet or a brief, gentle abdominal massage downward toward the bladder to encourage flow. Do not strain or bear down hard. If you still feel incomplete emptying, a clinician can measure post-void residual volume using ultrasound. Elevated residuals change the diagnostic pathway. Nocturia that interferes with sleep. Shift evening fluids earlier. Finish most fluid intake at least 2 to 4 hours before bedtime. Avoid caffeine after mid-afternoon and alcohol close to bed. Time diuretic medications, if prescribed, earlier in the day if safe to do so after discussing with your prescriber. Screen for sleep apnea. Treating sleep-disordered breathing often reduces nocturia. Problems with adherence and motivation. Pick only 1 or 2 changes at first. For example, double void each night and remove alcohol for 2 weeks. Use a visible tracker, calendar, sticker chart, and attach a small reward to milestones. Involve a partner or friend as an accountability buddy when appropriate. Travel and long drives. Practical adaptations. Preparation. Empty immediately before you leave. Make pre-voiding a ritual. Bathroom, stand for 30 to 60 seconds, sit, and try again. Avoid bladder irritants in the 6 to 12 hours before a long trip. Coffee, sodas, alcohol. If you take diuretics or medications that provoke urination, discuss timing with your clinician so you can plan doses earlier in the day when feasible. During travel. For car trips, plan stops every 2 to 3 hours. If you find it hard to stop, aim to stop at least once every 3 hours. Stretch and walk at stops to reduce pelvic congestion. For air travel, use the aisle seat when possible, perform the pre-void ritual before boarding, and hydrate in smaller, spaced sips rather than large volumes at once. Pack a comfort kit, spare undergarments, an absorbent pad if you use them, a small measuring cup if you wish to track volumes, and wipes. Having these reduces anxiety and the tendency to over-restrict fluids. Managing medications and medical comorbidities. Make a list of current medications and review them with your clinician or pharmacist. Common culprits include loop diuretics, thiazides, some calcium channel blockers, and certain antidepressants. Do not stop prescribed medicines without professional advice. Conditions such as diabetes, heart failure, prostate enlargement, neurological disease, and chronic constipation can drive urinary symptoms. Addressing the underlying condition often improves bladder control. If lifestyle and behavioral measures fail after a clear trial and you remain troubled by symptoms, the next steps may include pelvic floor physical therapy and biofeedback, pharmacologic therapies, antimuscarinics, beta-3 agonists. Each has potential side effects, dry mouth, constipation, blood pressure effects, so discuss risks and benefits. For men with suspected bladder outlet obstruction from prostate enlargement, targeted options such as alpha blockers or 5-alpha reductase inhibitors may be considered. Specialist tests, uroflowmetry, post-void residual measurement, urinalysis, and, in select cases, urodynamic testing help define whether urgency arises from overactive bladder, reduced flow, poor emptying, or a mixed picture. When to seek prompt evaluation. Seek immediate medical attention for sudden inability to pass urine, significant blood in the urine, fever with urinary symptoms, or severe new pelvic or abdominal pain. Arrange a timely clinical visit if symptoms worsen rapidly, if you fail to improve after a reasonable trial of behavioral measures, or if you develop new neurological symptoms, weakness, numbness, changes in gait, loss of sexual function, as these may require urgent assessment. A suggested 2-week starter plan you can follow tonight. Week 1. Choose one dietary change. Skip alcohol or cut coffee. Track it. Begin double voiding each night and in the morning. Time voiding every 3 to 4 hours while awake. Walk 10 minutes after dinner. Week 2. Continue the above. Add a pelvic floor relaxation rehearsal twice daily. 2 slow diaphragmatic breaths, gentle bearing down release. Keep a 3-day bladder diary over days 10 through 12 and review the numbers. How to present results to your clinician. Bring your diary, the number of voids, volumes if available, nocturia count, and recent medications. Explain which behavior changes you tried and what improved and what did not. This concrete data lets the clinician tailor next steps, medication selection, referral for pelvic floor therapy, or further testing. Dealing with setbacks and plateaus. Change rarely follows a straight line. You may have a week that looks worse. Illness, travel, constipation, or changes in routine can trigger relapse. Respond with curiosity rather than blame. Return to the basics, fluid timing, scheduled voiding, and your nightly double void. Reassess your diary and adjust one variable at a time. A word about expectations. Many people notice early wins, less leaking, longer stretches between voids, better sleep within weeks. More durable changes often take months as body habit and physiology adapt. The goal is measurable improvement in daily life, fewer urgent interruptions, more confidence, and restored sleep. If that progress stalls, there are safe, evidence-based options to consider with your clinician. Finally, remember this is a team effort. Your day-to-day choices provide the information clinicians need to offer targeted help. By tracking, practicing the simple rituals we discussed, and addressing obstacles one at a time, most people move from reactive frustration to predictable control. Keep the diary, pick the one habit you will start tonight, and let the small, consistent actions build the change you want to see. Practical checklists for the next clinic visit. Bring a 3-day bladder diary, times, volumes if known, leaks, pads used, fluid intake patterns. List current medications, including over-the-counter remedies and supplements. Note any recent changes. Describe sleep pattern and nighttime awakenings, in plain terms. I wake twice to pee, each time after 2 hours of sleep. Record recent events that may have changed symptoms. Travel, constipation, new exercise, illness, new stressors. Be ready to say which single habit you chose to start, how consistently you did it, and what changed. A realistic 6-week follow-up plan. Weeks 1 through 2 focus on one dietary change, scheduled voiding every 3 to 4 hours, and nightly double void. Keep the bladder diary. Weeks 3 through 4 add the pelvic floor relaxation rehearsal and start short walks after meals. If pads are used, try a lighter pad as confidence improves. Week 6, review the diary with your clinician. If objective gains occurred, Continue and gradually add another habit, strengthening or timing change. If no improvement or symptoms worsen, discuss stepped-up options. When to expect further tests or specialist referral. Consider referral to a specialist when symptoms are severe despite behavioral measures, there is significant post-void residual urine, recurrent urinary tract infection, suspected neurologic cause, or bothersome pelvic pain. Common tests used by specialists include urinalysis, post-void residual measurement, uroflowmetry, and urodynamic studies. These clarify whether the problem is primarily storage, overactive bladder, emptying, poor flow, obstruction, for example, prostate enlargement, or mixed. Overview of further treatment options, what they are and what they aim to do. Pelvic floor physical therapy and biofeedback, targeted training to improve coordination and relaxation of pelvic muscles, non-invasive and often first line when simple exercises alone are insufficient. Medications for urgency, drugs that reduce bladder overactivity or change bladder muscle signaling. Benefits must be weighed against side effects, dry mouth, constipation, blood pressure effects. Discuss alternatives and monitoring with your clinician. For men with suspected obstruction, focused medical therapy to relax prostate smooth muscle or reduce its size can improve flow in urinary symptoms. These decisions follow objective assessment. Minimally invasive or surgical options, urethral bulking agents, mid-urethral smings for stress incontinence, transurethral procedures for prostate obstruction, intravesical botulinum toxin for refractory overactive bladder, and neuromodulation, sacral or posterior tibial for selected patients. Each has benefits and risks. Candidacy depends on accurate diagnosis and on patient priorities. Practical advice about devices and caregiving. Use absorbent products that match your activity needs. Test different sizes and blends for comfort and discretion. Change pads regularly to maintain skin health. Catheter use. Intermittent self-catheterization is taught and supervised by clinicians for those with significant retention. Chronic indwelling catheters have important risks and should be managed with clinical support. Do not begin catheterization without instruction. If a caregiver helps you, keep simple logs and clear instructions about toileting times, fluid schedules, and signs to report. Fever, pain, new confusion. Sleep and nocturia strategies. Restricting evening fluids and avoiding late alcohol often helps. Time diuretics with clinical advice earlier in the day when possible. Treating underlying causes, sleep apnea, heart failure, peripheral edema can also reduce nocturia. If nocturia persists and disrupts sleep despite behavior changes, raise this specifically with your clinician. Nocturia has distinct causes and may require targeted management. Addressing emotional, social, and sexual effects. Urinary symptoms commonly cause embarrassment, social withdrawal, work disruption, and sexual difficulties. These are valid concerns. Seek support. Talk with your clinician, a pelvic health therapist, or a counselor experienced in these issues. Simple, practical changes often restore confidence. When they do not, focused help is available. Partners can be part of the solution. Clear communication about timing, intimacy, and shared strategies reduces anxiety for both. Managing setbacks. Expect variability. If travel, illness, constipation, or a busy week causes relapse, return to the basics: scheduled voiding, fluid timing, and your nightly routine. Reassess the diary and adjust one variable at a time. Celebrate small wins. Final encouragement. You have already begun the most important work, noticing patterns and trying a concrete change. That small experiment, one dietary tweak, one new timing habit, one short pelvic rehearsal, gives your clinician the data needed to help you further. Improvement is rarely overnight, but predictable progress is common when steps are repeated and assessed. Keep the diary, bring it to your appointment, and ask the specific question you most want answered at the visit. Can we try pelvic floor therapy next? Or is this medication likely to help my sleep? With measured steps, partnership with your clinician, and a willingness to iterate, most people regain control, confidence, and better sleep. If you need a one-page summary to bring to the clinic, copy this checklist: bladder diary, medication list, single habit tried, and the top 3 symptoms that bother you most. That simple page often makes the difference between vague concern and a targeted plan. Go on with the small, steady work you've already started. It matters. You are not alone in this, and help is available.